I gave a case-based presentation where I chose two real-world cases from my own clinical practice, both of them selected because they allowed me to showcase some of the newer developments and some of the current treatment algorithms in CMML, so use them as a framework for that. The first case was of a relatively younger patient, 63-year-old gentleman who had higher risk CMML with some high risk mutations and a blast count of 10%, fit guy, which allowed me to discuss the current role of transplant, particularly in CMML, discussed various aspects of that, including some of the more recent publications and guidelines. So some of the sort of key messages of that were some recent retrospective data, large 1,000 plus patient studies from international registries that have shown that transplant in CMML, certainly for lower risk patients, is not recommended. And even amongst higher risk patients, the results were still rather circumspect. The take-home message of that particular study that I discussed was that if you're higher risk disease, according to some of the prognostic scoring systems, if you live for 2 years after your transplant, then you're going to do much better with a transplant. But if not, then you would have been better off not being transplanted, which is a bit of a conundrum. And so it's still quite challenging to know which patients to select. I went on to discuss some recent expert consensus guidelines published last year. And a couple of the sort of interesting messages from that set of recommendations are that whereas we have traditionally given induction treatment, whether it be chemotherapy or hypermethylating agents beforehand, in CMML, probably because of the age and the comorbidities of these patients, very often they have real difficulties with that treatment, and so many patients don't make it to transplant. And so actually the recommendations are to try and take people to transplant as quickly as possible if you're going to transplant them, which is a bit of a departure from previous, especially as they recommend doing so irrespective of blast count. My case was quite a good one to showcase that because it was a case that didn't go well. It was an example of that. This very fit gentleman who we did give chemotherapy to, and he had a torrid course, a very prolonged aplasia, multiple infections, fungal infection, liver and kidney failure, and ultimately was unable to go and proceed with the transplant and sadly died 4 or 5 months after being admitted for treatment. So I think it was a useful showcase as to sort of why those recommendations are out there. So that was the first case. It also allowed me to discuss a little more about the latest prognostic scoring systems. A headline that I think is worth mentioning was some data from ASH last year, which showed that the IPSS molecular designed for MDS, not CMML, but the outcome of that study was that it was as good, if not perhaps slightly better in CMML than the CPSS MOL scoring system. I think the jury's still out on that, but I think that's interesting. It certainly includes more molecular information. And it also allowed me to discuss the latest classification changes from 2022, notably that the monocyte threshold has been reduced from 1 to 0.5, which many viewers will be aware of. There was another study at ASH that I discussed that actually looked back at a large database of MDS and CMML patients and showed that as many as 25% of MDS patients would now technically fall into the CMML diagnostic category, significantly increasing the frequency of the disease. So that was the first case. The second case was slightly different. An older patient, 75, some modest comorbidities, but generally fit, who had proliferative type CMML, not a transplant candidate. So again, we discussed the risk scoring of this patient. But transplant not being an option, it allowed me to then introduce the current management algorithm for these patients, whereby the standard of care for proliferative CMML in most countries would still be considered hydroxycarbamide and the importance of clinical trials. So I introduced the AMMO clinical trial, which is one that we've been running in the UK. It's a phase 2 study comparing a novel oral hypermethylating agent, ASTX727, which is now FDA licensed, FDA approved and widely used in the US, not available in the UK. And it's comparing that against best supportive care with or without hydroxycarbamide. The trial recruited extremely well. We completed recruitment of 77 patients 7 months ahead of schedule, which I think shows the appetite for trials amongst these patients. And we're hoping to get the results in May. Now, this patient I presented was someone who went on the study, and I explained how well she did. She had a dramatic response. Her white count, which had been shooting up, returned to normal very quickly. Her renal function, which was deranged, also normalized, which allowed me to discuss some of the ways in which CMML causes renal dysfunction, and that can resolve with successful treatment. She stopped needing blood transfusions, and her quality of life massively improved. She hasn't spent a day in hospital through 17 cycles of treatment. And then I finished really by going on a whistle-stop tour through some of the newer treatments and trials that are coming along for this disease. CMML is quite a rare disease. Many community physicians may not see that many CMML patients. And unfortunately, over the years, it's been rather neglected by research and clinical trials. It's often just been included as a subgroup of MBBS trials, for example. And as a result, we don't have many treatment options available. So, the current management algorithm would really begin with an assessment of risk to decide whether treatment is required or not. We would apply one of the various scoring systems. CPSS molecular is one that people may be familiar with. It's my favored one at the moment. And for those with higher risk disease, generally we consider that to be intermediate 2 or high risk categories, as opposed to the intermediate 1 or low. Probably do justify treatment in most cases. And if that's the case, then really our two major options are for proliferative subtypes, so that's those with white count above 13. If they need treatment, it would usually be with hydroxycarbamide. The general feeling is that although you can use other chemotherapy approaches, they probably add little over hydroxycarbamide except extra toxicity. The level at which you would treat is not, there's no real consensus on that. My personal approach would be tailored to each individual case based on symptoms and patient preference, but broadly consider at a white count of 30, particularly if there are any symptoms. Obviously consider at lower levels if there are problems, for example, renal failure that you may want to try and improve. If asymptomatic, though, it might be reasonable to watch and wait. And at around 50, I'd start to get a bit twitchy. But there are patients who are very well and are not keen on therapy. It's not curative treatment after all. And so sometimes it's reasonable to let the white count go higher. The other obvious group of agents for this disease are hypermethylating agents, azacitidine being the one available in the UK. Technically, it's only NICE approved for patients with blast counts of above 10% in bone marrow, and technically only for those with non-proliferative subtype. So that's those with a white count under 13. And so there are definitely patients who can benefit from azacitidine, but it generally works less well in CMML than in other diseases like MDS, and hence the need for newer trials and treatments. Blast phase CMML represents when CMML transforms into acute myeloid leukemia, based on the standard definition of 20% blasts in blood or bone marrow. It happens in probably 20 to 30% of CMML patients at some point in their course. And it results in a really devastating form of AML that has a particularly dismal prognosis. I think many viewers will probably have experienced that. It's a very difficult AML to treat, and really very few things work. Even transplant has very poor outcomes in that group. So our recent work was to try and better understand blast phase CMML. It's not been very well studied. And so what we did was we took, we confirmed the poor prognosis in a very large cohort of patients, and we confirmed, as expected, the median survival was less than 6 months for these patients. And in our lab, we have access to a large biobank of samples, which included 40, that's right, I think it was 44 cases where we had cells stored in the bank from the chronic phase, but also after transformation to blast phase. And we had a look at various parameters to try to sort of better understand whether these are all the same or whether there's any heterogeneity amongst these cases, and see if there's anything there that could be exploited to improve therapy. And the upshot was, by looking at various factors, we looked at the immunophenotype of the blast phase CMML, we looked at the mutations, and we also did RNA sequencing on all of the blasts from the blast phase CMML. We did some machine learning to try and sort of separate these out into distinct subcategories, and we found some interesting things, and particularly that it is very heterogeneous, and there did seem to broadly be two subgroups. So whereas most people think of CMML transforming to a monoblastic or monocytic subtype of AML, that's only the case in just in around half of cases, and quite often the transformation occurs in a much more primitive stem cell, so you get a much more sort of N0, N1 type AML than one might expect from CMML. And we show important differences in therapeutic sensitivity between these two subgroups. We showed particularly poor responses to venetoclax or Ven/Aza, more so in the more mature sort of what we call the mature subtype transformation. And we also looked at drug sensitivity profiles and tested a range of existing novel compounds and showed quite different sensitivity patterns across this sort of spectrum of maturation. So it's discovery work at this stage, but it could serve as a framework for future clinical trials whereby, we might be better off defining the subtype more than just saying that they've transformed to AML. And we might start to treat them based on the type of AML, particularly focusing the existing drugs differently. We may be looking for other things in the more mature subtype AMLs than standard Ven/Aza, which would probably be the standard of care, but we know doesn't work very well. And also as a framework for future clinical trials where we could potentially try and target specific novel therapies to specific transformation subtypes. Yeah, so this is something I did discuss a little bit in the talk at the meeting. So there are quite a lot of interesting things happening. I think it's worth mentioning, just looking to the future, that there's quite a lot of attention being given to this. For example, in the US, the Leukemia Lymphoma Society have had a recent CMML special initiative. A very large donation has allowed them to fund a whole range of projects specifically to try and improve outcomes in CMML, two $5 million grants for two consortia to work on different projects, 4 standalone drug development project grants, money for a clinical trials network. So I think the future does look much brighter. Amongst the sort of most promising agents in development at the moment, one that I'd like to mention would be a drug called lenzilumab. So this is a monoclonal antibody that targets GM-CSF receptor. And, this is something to which CMML cells have hypersensitivity. They seem to respond without the need for the ligand receptor binding. And that probably drives some of the more proliferative subtypes of the disease. It seems to be associated more with RAS mutant cases. And so these are some of the ones that need treating and have the worst prognosis. This drug's been around a while. It's been used in a lot of patients. It's very, very safe. It has barely any side effects. And in the CMML setting, it's been through phase 1 trials, showing some responses. And at ASH last year, an Australian study presented the first 23 patients, I think, with some really quite spectacular results. This was a single-arm study. It was a slightly bigger study than just the Lenzilumab. There was another arm to it. But for the Lenzilumab-treated patients who had RAS pathway mutations, they received Lenzilumab alongside azacitidine. And there were some really impressive durable responses, and they also showed a reduction in allelic burden of some of the mutations, something we don't tend to see with azacitidine. And the results were really quite impressive. At ASH, they compared to historical cohorts of HMA-treated patients. That's obviously open to interpretations as to whether that's a good thing to do or not, but the comparison was really very striking. The response rates and duration and survival were significantly better with the addition of Lenzilumab. So what's needed there is direct randomized trials of the combination, and there are discussions about those taking place at the moment. So we're quite interested, and there may be a trial of that coming to the UK soon. Another drug I'd like to mention is a monoclonal antibody that targets a protein called LILRB4. This is a slightly earlier stage of development. So this is a protein that's expressed on antigen-presenting cells and is highly expressed on some CMML samples. And this monoclonal antibody, again, has been tested in phase 1 studies and seems to be safe. And there were definite responses seen, and interestingly, the responses were very closely linked to the expression level of the protein. So if you have a lot of the protein, you respond better, which is a pretty good sign that this is an on-target effect. And there's enough interest around this that the FDA have granted it orphan drug designation status in CMML, which doesn't happen very often. So we're quite interested in this drug. And there's a phase 2 ongoing in the US at the moment. No current plans for it to come to the UK. One other thing I might just mention in this is about JAK inhibitors. There's a number of these. There have been trials of ruxolitinib in this disease. Those results have not been spectacular, although there are responders. There is interest, though, in some of the other JAK inhibitors. One that I'd mention is perhaps pacritinib, which has some potential advantages in CMML, and there's certainly interest in trying that drug in this disease. This is a JAK inhibitor that's obviously licensed and used fairly widely in myelofibrosis, but is notable for being safer in thrombocytopenia, which is helpful because a lot of CMML patients are thrombocytopenic. But more so, it's to do with the different tyrosine kinase targeting profile of that drug. It's not just hitting JAK2, it also hits something called IRAK1, which we know is overexpressed in CMML. And it also hits CSF1R, which is the monocyte colony stimulating factor receptor, again, with a potential role in driving some of the more proliferative CMML features. So we think that this could be an interesting drug in CMML. So these are at reasonably advanced stages of development and certainly will be coming to trials soon. So, this was a small study that we published quite recently last year, which is one of the curious things about CMML, particularly for a disease like this, particularly prominent in the elderly, is how rare P53 mutations are. It's the most common mutation across all of cancer, and yet you hardly ever see it in CMML. Nobody really knows why. So the first thing we did was we looked in a large cohort of patients. We gathered 650, nearly, I think 648 CMML patients from across the Northwest for which we have good clinical correlative data and outcome data. And we confirmed that was the case. Less than 2% of the patients actually had a TP53 mutation, which is much lower than you'd find in, for example, MDS or AML, or indeed, myelofibrosis. When it goes bad, very often accrues a TP53 mutation. It's not the case. So, that was interesting. But then we had RNA sequencing data on a lot of these patients, and we identified that there's about 15% of CMML patients seem to have unusually low TP53 expression. We don't know why, but they were quite different from the rest of the CMML patients, and they had a worse prognosis. So it would appear that in this disease, the expression is more relevant, certainly to a greater number of patients, than mutations. And importantly, we showed ex vivo, so in the lab, we haven't taken it to patients yet, but there is a drug that targets both MDM2 and MDMX, and basically functions as a P53 activator. These drugs have been tested in early phase trials in AML and MDS, and we showed that there was synergy with azacitidine in CMML samples in the lab, and did seem to correlate and be a greater effect in those in this lower expressing subgroup. So again, just with the goal of trying to personalize therapy for CMML patients, we don't have very many therapies at the moment, but what we would like to be able to do is try to find newer therapies, but then target them to the right subgroups of patients. And, this could be another approach, and, that might be relevant to a meaningful proportion of CMML patients. Needs to be tested in trials, though.